Guys, hello family, hello friends. Once again, welcome back to my channel, Clinical Medicine with Dr. T. So once again, guys, I'm going to ask you to please comment, subscribe, even a hi, a hello. You can type something like, I'm here, I'm watching. You don't have to type anything extensive if you're shy. So it helps my channel to grow. Your comments, they help my channel to grow. So the first part of this series, I can see you guys are liking it, and thank you so much for those who are watching and we actually liked. So I'm going to be doing now part 2 of my experience as a ComServe medical officer. So guys, whenever I post a video, it's not to say I've made it. I'm just a junior doctor, but I have a passion for sharing information and teaching. That's it. And it's not to say I'm better. It's not to say I've made it. It's not to say I don't make mistakes. I make mistakes, and I'm learning each and every day. I'm learning from my own mistakes, and I'm learning from other people's mistakes as well. So yeah, so in this section, I just want to share with you guys about my experience working in maternity as a maternity doctor. Like I told you guys that when you work in this kind of hospitals, like level 1 hospitals, there are no departments. So I'm not gonna be saying I was working in obs and gynae, because we don't have obs and gynae. We've got maternity and the gynae part. Those patients are not seen only they're not seen in maternity. They are seen in OPD, and they get admitted in a surgical ward if they've got a surgical condition, a medical ward if they've got a medical condition. So they're not admitted in we don't have an obs and gynae ward. So as a maternity doctor for that 3 months I was there. So I was there in January, February, March, April, May, June. So that's when I was working in maternity. And one of the reasons why I wanted to start by sharing my maternity experience with you is because I know that a lot of people, they are scared of maternity, and the tips that I'm going to be sharing with you will actually be worthwhile, and I'm sure that you're going to enjoy them, and you're going to need them. Most importantly, you're going to need them. So if you're going to be doing your ComServe next year, you better listen attentively, because even if you're not gonna, because I know there are ComServes that finish their ComServe, their 12 months of ComServe without ever working in the maternity. But during your call, which I'm going to talk about that in another video, how do calls work out here, how do we do our calls here. So when you are on call, you might not work in maternity, you might not rotate in maternity, but during your call you will be called in maternity. So I mean, working in maternity is stressful for everyone. It's scary for everyone. It's we all know what is happening there, the litigations and all of that, which I'm not going to be talking about now. So I mean, another thing, one of the things that makes maternity what makes let me just say obstetrics, working with obstetric patients, is that one of the difficult things, or one of the challenges, is that there is little room for error. There's small room for error there. Any small mistake can actually have a big impact, and a very poor outcome, disaster, can happen anytime there. So it requires someone who actually, you can't be lazy and do obstetrics, because as much as it takes its toll on you mentally, it also takes its toll on you physically. It's very physical. So you work hard there. You really work hard there. And also another tiring thing about maternity is that, or another tiring thing about pregnant women is that when you see them you have to be thorough all the time. You have to be fully focused all the time. And being fully focused and paying attention all the time is difficult. And that's when errors starts to come. That's when mistakes starts to actually come up, and you find yourself in trouble. Unfortunately, whenever you see a pregnant woman, you have to be thorough. You have to apply your mind, and that's not easy. It's not easy to pay attention 100% from 8 to 4 every day. It's not easy. That's why people who are competent, you find them making errors, not because they are incompetent, because you just cannot function at your best all the time and in all the patients that you see, because we see a huge volume of patients. But we do try our best. But these are the things that I picked up when I was working there, that it makes sense why we see some of the things that happen there. In any case, so when you are a doctor working in maternity in a level 1 hospital, what are your duties? Like I said, the only patients I was seeing during that 3 months are pregnant women. Not just pregnant women, but those who are pregnant from 22 weeks going up. So when I wake up in the morning, I go there, and my first station, I would always go to the antenatal care, the admitted ANC patients. That's where I would start. I would see all of them. So the patients that I would admit there, it's different. Like I said, they must be 22 weeks going up. So they'll be having different assessments. Some would have, maybe I'm waking them up for, maybe they came in with a high blood pressure, but I just don't know their PT bloods. So maybe I'm waiting for bloods to see how their PET bloods are. Unlike in big centers, the turnaround when it comes to bloods in our hospitals is like very, very slow. You can't do bloods and get them the same day. So that's one of the things that I challenge when you work in these hospitals. So maybe the patient came in with a high blood pressure, but I am not sure, as much as I know that they've got a PIH, but I don't know the extent, I don't know the grading, I don't know the actual diagnosis. I'm just going to say this. As a doctor, you should try and avoid writing PIH on a patient's file, because when you write PIH, it's like PIH is an umbrella term to start with. It's an umbrella term. So if you write PIH, you're actually telling the next person that you don't know whether they are eclamptic, you don't know whether they've got HELLP syndrome, you don't know whether they've got preeclampsia or preeclampsia with severe fissures, you don't know whether they've got gestational hypertension, you just don't know. All you know is that they've got PIH. And writing PIH on a patient's file means that you won't know how to manage them, because 2 patients can have PIH, one can have eclampsia, one can have gestational hypertension. Their management will be different because of the grading of the PIH. I mean, eclampsia is the highest grade of a PIH, right? Then you've got your other, like your HELLP syndrome, you've got the preeclampsia with severe features, and all of that. So try, and because writing PIH, you most likely you won't manage the patient properly, because once you say PIH, you have been actually committed to a specific diagnosis, and a specific diagnosis with a specific management, right? Okay, I'm not gonna talk about PIH in this video, just making an example. So other conditions that I would admit there is maybe someone who came in with low abdominal pains. They thought they are in labor, but I'm just waiting to see if they will be in labor in the next 24 or 48 hours, or maybe they're in the latent phase of labor, or maybe I've admitted them because they've got vaginal discharge syndrome, or maybe they've got a UTI. I'm just making sure, is it really UTI? I'm waking them up. or maybe they've got anemia in pregnancy, or maybe they came in maybe with a chest infection, or they came in with so different conditions. So on a Monday, I would see maybe about 30 patients in that unit, because what happens is that whenever a patient comes into maternity from home, that patient will be kept. If it's not an emergency, the nurses will keep that patient for me to see in the morning and decide what is happening. Not unless it's an emergency, then they would call the person who's on call to come and see the patient. So so all the other patients that were not emergencies, that were admitted, because the nurses, whenever you are pregnant, you come and present with whatever symptom, they will keep you until the doctor sees you. So usually Mondays, they're always packed there. I would say about 30 patients. And then that would be my ANC and other conditions. The list is just endless. Then from there, I would go to post-natal. So postnatal would be patients that have done C-sections. I would see them, check that they are well, their wounds are okay, they're not bleeding, their wounds are not gaping, they're not septic, their vitals are fine. So I would see those patients, make sure that they're getting their antibiotics, their painkillers. Then when I'm done, if there is an NVD that has got issues or complications, then I will also see that patient. The nurses will tell me to see that patient. And then, so I would have about 8, 10, 11, 12 patients there on any given day. Sometimes if it's maybe a very good day, maybe I would say about 3, there will be about 3 to 4 patients in that postnate. Then when I'm done, I would see the patients that are in labor, see all of them, and see how they are doing. Are they progressing well? Do we need to send any of the patients for operation or whatever? So I would see those. Maybe there will be about 2, 3, sometimes 1, depending on the day. And then after if I have a Caesar, I would then go and do a Caesar. Then come back and start the clinic. The clinic, it's the ANC clinic that I'm talking about. So that clinic runs, in our hospital, it runs from Monday to Friday. And then the heaviest days are Monday, Tuesday, and Wednesday. Then it starts to get light on Thursday, and then very few patients on Friday. On Monday, Tuesday, Wednesday, Thursday, average of 20 patients that come to the clinic. So all of them are pregnant. Then they would come with different presentations. Some would come in just for a dating ultrasound. Some would come in because they are sent because of high blood pressures. Some would come in because they are swollen. Some would come in because they have abdominal pains. Some would come in because they've never felt fetal movements, or they haven't felt fetal movements for maybe a day or 2. Some would come in because they've had previous abdominal pregnancies. Because the clinics, when a pregnant woman has had a previous abdominal surgery, they would send those. They regard them as high-risk patients, so they would send those patients to be sent and to do their ANC at the hospital. So the ANC was it's one place that I enjoyed working, because seeing those patients, you can actually plan everything. You can actually see things before they become a problem. You can actually, if you've got a low-lying placenta and the patient is very close to delivery, maybe they're about, when you see a low-lying placenta, especially in the 3rd trimester, you want to see that patient again so that you can send them early enough, because they're going to be a previa. Most likely they will be a previa. So rather than waiting for them to come in as a previa and they're bleeding, you want to see them now and actually send them when they are maybe a week before term, so that their delivery can be planned. You don't want a placenta previa to start bleeding. You don't want that. And also you would pick up some twin pregnancies there. You would